Hello, and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on Pyoderma Gangrenosum under the section of Dermatology. What is Pyoderma Gangrenosum? It's a cutaneous disorder of unknown etiology, and it has a mixed inflammatory infiltrate with necrosis, thrombosis, and or abscess formation on histology. And it's associated with numerous secondary conditions that we will be covering in the next few slides. As for its epidemiology of Pyoderma Gangrenosum is unknown. However, about half of the cases are associated with secondary conditions. These secondary conditions, the most important of them for you to be aware of are number one, malignancies, and they include colon, prostate, breast, leukemia, lymphoma, and MGUS. Autoimmune disorders such as rheumatoid arthritis, Behçet syndrome, systemic vasculitis, and finally, gastrointestinal disorders, including inflammatory bowel disease, such as ulcerative colitis or Crohn's disease, sclerosing cholangitis, chronic active hepatitis, and primary biliary cirrhosis or PBC. The sign and symptom of Pyoderma gangrenosum is typically a tender erythematous or hemorrhagic nodule that can happen anywhere in the body. However, it usually presents on the shins. They are normally rapidly ulcerating and enlarging. They contain irregular raised edges on an erythematous base and margin and can sometimes be accompanied by fever. So this picture is supposed to be showing you a classic case of Pyoderma gangrenosum. As you can see, it looks almost like an infected large ulcer on an erythematous base that's happening on this patient's shin. The investigation of Pyoderma gangrenosum really relies in the history, and your job is to make sure that you're not missing on any other potential associated condition that could be causing the pyoderma. Clinical examination would be also crucial to exclude other conditions such as an infected ulcer or cellulitis, for instance. And really, anything else that you pick up as part of your history or clinical exam, you would be arranging for the appropriate test and investigation to lead you towards a potentially secondary diagnosis. Ultimately, the gold standard diagnostic test is really important to know that is a biopsy. However, very frequently, you do end up swabbing these patients' wounds to exclude concomitant infection. The treatment of Pyoderma gangrenosum really depends on treatment of the precipitating factors and the secondary causes. The treatment is with immunosuppressants in the case of high-dose oral steroid or IV steroid, and for subacute cases, frequently you can use minocycline. In specialist cases, under the advice of dermatologists, other immunosuppressants such as sulfasalazine, dapsone, cyclosporin, and azathioprine are used. And even for very severe and rapidly progressive cases, biologic drugs such as infliximab can be considered. It has a variable prognosis, and it heavily depends on optimization of treatment of the secondary cause that's led to the development of Pyoderma gangrenosum. Let's do some questions. A 30-year-old lady with a history of inflammatory bowel disease or IBD and previous right-sided colectomy and functioning stoma presents with a new ulcerating lesion adjacent to her stoma site. A bacterial swab of the ulcer shows no growth after 48 hours. Given the previous medical history, what is the most likely diagnosis? The options are A. Erythema nodosum, B. Pyoderma gangrenosum, C. Melanoma, D. Basal cell carcinoma, E. Progression of inflammatory bowel disease. So the correct option in here is option B, which is Pyoderma gangrenosum. If you go over the history again, you have a lady who has a history of IBD that counts as one of the highest risk factors to develop pyoderma gangrenosum. She presents with an ulcerating lesion over her stomach. We said that pyoderma very frequently affects the shins. However, they can technically happen anywhere. This lady clearly at the site of her stoma has been a site of chronic inflammation just by nature of having the stoma. And that's your second risk factor that could potentially lead to development of pyoderma gangrenosum. The other options are incorrect because the way that the clinical vignette has described this, it doesn't really match with the others. So erythema nodosum, they cause erythematous tender, usually shin lesions. They don't cause ulcerating disease. Melanoma is very unlikely to happen on somebody's abdomen, and it will need to be really, really advanced for it to be ulcerating. Basal cell carcinoma, again, is irrelevant because it classically causes a pearly-like lesion, and it's not really common to affect the abdomen. If you want a review of BCC or basal cell carcinoma, please click here. Progression of IBD, it could be a potential option. However, you would be expecting to have more information about this lady's symptoms. And main symptoms of IBD, if it was to progress, would be abdominal pain, would be bleeding, whether PR bleeding or bleeding from the stoma site, having a raised temperature, raised inflammatory markers. And quite frankly, none of those are mentioned in the clinical vignette. Therefore, the most likely option in here is going to be option B, which is pyoderma gangrenosum. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.